We're live. Thank you. Thank you very much, and thank you everyone for coming along today. Sorry, slightly late start. The weather has affected all of us. So welcome everyone. There's a lot of people around the table. I don't think we'll do around the table introduction because it will take forever. So if when you speak, if you just introduce yourself, I think that'd be probably the best way if everyone's happy with that. So we will start. George, thank you. Do we have any apologies?
Yes, we do. We have apologies from Councillor Spencer Flower, from Vivian Broadhurst, John Selgren, Martin Longley, and that's it.
Lovely, thank you. And we obviously have people here online as well. Teresa's here online and in the room. Yeah. Very impressive. Have everyone seen the minutes from the last meeting? Are you happy with those if you were here? Yes? Yes, nods all round. Thank you. Good. Do we have any declarations of interest to declare? No, thank you. So can move on to public participation. I don't believe there is any. No, nothing. Shame. And no questions from councillors have come through. No. Okay. Whizzing through agenda item 6, we will move on to the Better Care Fund, which Sarah today is going to run through. Thank you, Sarah.
Okay. Okay. Good afternoon, everybody. My name's Sarah. I'm Sarah Sewell. I'm Head of Service Commissioning for Older People and Home First for Dorset Council. The paper that I'm presenting today is a seeking your retrospective approval of the Better Care Fund plan for 23-25. You've got the reports in your pack with appendices A and B, and I've just picked out a few kind of headlines and kind of key points to note just in this short presentation. So just by way of kind of some of the headlines, so the Better Care Fund provides Dorset this current financial year with around about £146 million in funding. You'll recall from previous presentations that from this financial year, NHSE have moved to a 2-year planning round for BCF. So that's really good news for us. It allows us to be more sort of certain and forward plan more with the funds we have available to us. And on the 28th of June, we submitted our jointly developed plan under delegated authority. Since then, the plans work through the BCF assurance processes, and subject to your approval today, the NHSE Regional Director has recommended that our Dorset plan be approved by the national BCF partners. Just to remind you around some of the kind of the key framework of the Better Care Fund. So the policy objectives echo our local shared priorities, and that's around enabling people to stay well, safe and independent at home for longer, and to provide the right care in the right place at the right time. And the policy framework continues for 23-25 in line with previous years. So we have a set of national conditions that we have to evidence that we meet, and also we have our performance metrics measured against national sort of metrics. So these are just a couple of sort of key changes and opportunities that I wanted to flag to you. So within the appendices, you'll be able to see that working together across social care and health, we've added new lines of health investment from this year, which equate to around about £5.3 million a year. And that's in relation specifically to our Home First Accelerator programme and our enhanced home care. We call it Recovery and Community Resilience, RCR. So there are additional lines within the plan this year. And those interventions are really sort of supporting our performance. You might recall we reported in the year end plan last year, but how we'd met the performance around admission avoidance and discharge to usual place of residence, and those kind of those schemes were supporting us meeting those measures. And just to kind of flag, within the report pack of Appendix B, section 5 and 6 gives you information about that Home First Accelerator programme. So that's quite a good piece of work and really making a difference in the early stages that we're seeing. So just in terms of kind of how we can then utilise those schemes in other ways as well. So in preparing for winter, those RCR resources, recovery, community resilience, we're able to create additional capacity on a more flexible basis. So we can turn up, if you like, the support that we've got available to help with sort of surge planning across those pathways. So we've put a bid forward to Home First Leeds where we can increase that capacity by 25% heading into winter. So it just gives us that flexibility to help with our planning. And in addition, there's other options that we're putting forward as part of our learning from BCF. So we're hoping to be able to expand the use of a telemedicine pilot that's being used well in care homes. So we're looking at how we could perhaps deploy that into those RCR schemes. So that's work that we're just working through at the moment. And you'll recall from previous reports that we're looking at how we can include all age commissioning schemes in those future plans as well. So we want to add birth settled adulthood into the schemes by the end of year 2. And we've started that work around broadening the all age commissioning elements by expanding our carers offer. So the carers schemes within the BCF are now to all age carers. And again, there's more narrative on that in section 8 of Appendix 2. So just a couple of other points just to note. So the Better Care Fund is a vehicle by which government are now releasing additional monies as they become available, sort of midway through the financial year. So you'll recall last Health and Wellbeing Board, we had a plan around the additional discharge funding that came in last winter. And again, for the 23-25 plan, we've got additional monies around that discharge funding as well. So great that the BCF is being used in that way, although just as a point of note, it does come with additional administration and we have to submit fortnightly and monthly returns against some of that additional funding. And also the demand and capacity modelling. And just to that point on demands and capacity, so that is now that planning tool is now an integral part of our submissions, and you'll see within the big spreadsheet on Appendix A, there's a sort of detailed modelling of demands and capacity. And whilst we've met our requirements within the plan around that modelling, it is an area where we think jointly that we need some additional input and expertise. So we've highlighted that to the national BCF leads. There's a support programme available and we're hoping to get some additional support just to work that through. Just in terms of next steps, so we'll be bringing probably another plan back to you at the next meeting, which will be our mid-year reporting plan. The guidance was about this week. Some technical issues, I haven't been able to download that quite yet, but that's the next step in the BCF cycle. And we'll continue to stay in touch with the work of the Integrated Care Partnership, particularly that Thriving Communities work stream. So just in terms of the recommendation today, seeking your retrospective approval of our plans for 23-25. Thank you.
Thank you very much. Are there any questions, observations from anyone? Sam.
Chair, thank you very much, Sarah, for taking us through that.
Do you just want to say who? Yes. Just identify yourself.
Sam Crowe, Director of Public Health, Dorset Council and BCP Council. Thank you very much, Chair. Thank you, Sarah, for taking us through the narrative report comprehensively. I guess my question is a looking forward question. I was really pleased to see the metric around falls included in the BCF, because sometimes, if I'm being honest, when I read the national requirements around what we have to report and the way that we construct the reports, it's quite hard to see the importance of some of the work. Don't mean to be critical when I say that, but there's a really good opportunity in here to connect the metrics around falls with some of the work that we would hope would happen in and around our communities, and particularly because the Health and Wellbeing Board had those case studies back in the summer of 2022, and we could see the impact of falls across the population. It's an issue under both councils. I think it's really encouraging to see the fall, because if I've got my understanding right, in 21-22, emergency admissions were a bit higher than what we're reporting in the current framework. So the question is for us as a board to kind of think about how we could bring forward that connection with the work a bit more strongly, because the framework is, I guess, restricted by the way that we have to report on the plan. But the really important thing is how our services and how is the work that people are doing with people in communities changing to be able to have an impact. And obviously in this plan, we've reported on the Ageing Well work and the investment by NHS Dorset be really good to see what are the plans beyond that. Are we able to sort of start to scale that? Are other primary care networks getting involved? Could we start to talk more strongly about the role of population health management and our data in reaching people early? And then what sorts of interventions are we able to put around people well in advance of that crisis moment when they might fall and actually have a significant event like a broken hip? So I think it's a question about how we start to link this with the rest of the system, make it more clear.
I come back on that, Jane. Jonathan Falls, Corporate Director for Commissioning for Dorset Council Adults. I think it's a really important point, and we do need to make the Better Care Fund a little bit more real. It's been quite a bland document over the last 6-7 years. So, falls, all age commissioning, all of those are areas that we would want to add in. And I think there is a little bit more room moving forward to have more local indicators in addition to the national ones. So with the support of the Health and Wellbeing Board, we can certainly look at that for the version that goes into next year. So, yeah, part of the possible.
Any yes?
Well, I was just going to add to that. What I'll do is it'd be helpful if we link you in with my Deputy Director of Health Inequalities, because the PHM function within the ICB sits there, and so we can then use that as a data feed to try and think about how we use that, as Sam was saying, in order to inform the creativity. Sorry, Paul Johnson, CMO for the Integrated Care Board.
Thank you.
Dorset. So I was just thinking about, just following on from Sam's point, that particularly focusing on falls is a good position to start in terms of what we see across the health and care system. One, because ever since the introduction of the trauma networks, we've seen a gradual change in the case mix of what arrives through the trauma networks. And actually, the last data submission showed about 65 to 70% of those presentations are actually not major trauma that you'd expect. They are falls from elderly people at less than 2 metres. So that has been a big change that sort of coincides with the change in the demographic of the country. There's a lot of work I think we still need to think about the earlier intervention upstream, and also how we support people beyond a certain age to maintain good bone health, and we're not doing enough in that space, and we've still got work to do there. But joining that work up through the BSF and then BCF, and then recognising actually how much that then translates to in terms of care costs beyond a fractured hip is going to be a really, really good exercise to do, because it can, if we get the intervention right. We were talking last night about the medium-term financial plan and how we integrate community primary care and then later on social care teams, and what that will mean around early intervention upstream. We're already starting to think about being quite conscious in our decision to start to move money as early as possible when we start to see the output from secondary care into out of hospital care and that whole prevention stream. And what does that then look like if we do that together? And the BCF might be a good place to start.
A good vehicle. Yeah. Any other comments, observations? Anyone on the screen? No? Okay. So the recommendation is to retrospectively approve the Better Care plan for 23-25. So everyone happy with that?
Yeah. Second.
A proposer, please. Sam, a seconder, please. Anyone? I'll second it. Thank you very much, Sam. Some detail. Right, we're now going to move on to next agenda item, which is birth to settled adulthood, which Julia, I think, is going to present.
I'm going to present a bit. Teresa has asked if she had to.
Yes, sorry,
yes.
a joint.
Thank you.
Absolutely. Oh,
We are on, thank you. Good afternoon, Teresa Levy, Executive Director for Children's Services, and presenting this jointly with Adult Services, where we've been leading with our health colleagues a really ambitious programme about making sure that we have greater life outcomes, greater good childhood and good young adulthood, and into a much better life for our young people with additional needs and disabilities. And there's been a huge amount of work in the last 2 years on this, and a huge amount of work across the workforce. And I think really getting very close now to a really clear picture around how we have a much more integrated service delivery offer for these young people as we go forward. So there's paper here which is not authored by either Julia or I, but Julia is going to present it, which is great. And thanks, Julia.
No, thank you. My name's Julia Ingram. I'm the Corporate Director for Adult Social Care Operations at Dorset Council. And along with Lisa Reid, who unfortunately can't be with us, I'm SRO for the service delivery part of the Birth to Settled Adulthood programme. And you've also got Claire Shields and John Price with you, who are also SROs on the commissioning side of that. It's actually a relatively brief report in content and detail. So I thought, with your permission, I'd supplement a little bit in addition to what Teresa's already said around the background. So just to echo Teresa's very important point, which is it was clear that we weren't delivering good outcomes to young people. It was very clear from both a health and social care perspective. And through feedback from the Parent Carer Council, young people, we were very aware there was a perceived cliff edge at 18, which needed to be rectified across the whole health and social care system. So the programme has been committed to securing a settled adult through the various transitions points that young people go through in that 0 to 25 arena, and recognising that there are particular cohort of young people who have complex health and social care needs, for whom transition into adulthood is a particular challenge, and also recognising that young people transition and develop into settled adult at different stages in their lives, and therefore we need services that could recognise and meet that. So the Birth to Settled Adulthood programme has had a number of areas of focus, a very clear and important integrated commissioning approach to make sure that our commissioned offer across health and social care, adults and children's, brushes out some of those barriers that we previously had to seamless moving forward for young people. Clear set of performance data that we could all understand and measure, and a clear understanding of the financial resources required to support this cohort. And then supporting that, a service model which delivers really good outcomes for people at place, providing them with a consistent and seamless support, and recognising, as I said, that young people mature at different ages. Importantly, a co-production approach has been used to developing this service model, and the 9-function wheel that you see in the report was co-produced by the Parent Carer Council along with the voices of young people, to make sure that the model that delivers those elements that are really important to young people as they mature. And we recognise as a programme that there's further work that needs to be able to be done to recognise that those 9 functions will have different meanings for different young people at different stages in their lives, and everything we have to do has to translate and be accessible to each of those individuals. Now, it's recognised by everyone on the programme that the ultimate goal is for an integrated model across health and social care, but it's also recognised that at this point in time, health is perhaps not in the same place to join into that integration journey at this point. So the first iteration of the model will be looking at how adults and children's services within Dorset Council deliver together a pathway for young people, and that will mean moving resources within our systems to make sure that we have really strong leadership in that space, but as I say, making sure that young people are supported in place. So at the partnership board in October, the proposal is to take a final model of a 0 to 25 service, which will then be implemented by April 2024. And that final model, as I've said, will deliver the 9 functions that are needed at place. And we've got a number of questions if the board is happy to consider them, because what we're really interested to understand how we think across health and social care those 9 functions can be delivered, and also how the NHS can remain aligned to this work while the iterations go forward, because we're really keen to make sure that health remains equal partners in this place, and that we're able to identify those opportunities for integration as they are emerged. And I'm sure that Teresa and Claire can perhaps identify more clearly than I can some of those natural opportunities. I'm thinking particularly of 0 to 25 CAM service and other elements which may provide us with opportunities earlier. So I'll stop there.
Thank you, Julia.
And I guess it's those 2 questions if the board's happy to consider them. And then, so the first one was, how do we support those functions? The second one is, how do we ensure that health remains aligned with this piece of work? And then I'm sure you'll have questions you might want to challenge us with.
Thank you, Julia. Did you want to do, before you do, I just wanted to explain that I wanted this to come to this board. I've been working as lead member on this since the beginning, and I absolutely know how hard everyone has been working to find a way forward, because it was clear that something needed to be done. It sounds sort of quite straightforward, really, when you just talk about it, but bringing all the various work streams together and the individuals and the layers that involve is highly complicated, complex, and has taken some time. And we are, I feel, treading closer and closer to where we need to be. But so I suppose I should have declared that at the beginning, that it was my suggestion to bring it. She was happy with that. So I feel very strongly about this, and I also wanted to have it out, to have this conversation out to perhaps partners around the table who may know nothing about it, so that we could all, be able to run through it and see where we could align on various aspects, but just to expose it, really, I suppose, in that sense, to everyone. Thank you, Teresa.
Thanks, Jane, and yeah, thank you very much, Julia. I think there's probably just some. It's always helpful, isn't it, to think about how would this change the child's life or the young person's life, really. So just, I guess, some illustration of that, where we're seeing some opportunities in this. And I was on the Southwest Transformation meeting yesterday with ICB colleagues from across the area, and it was a really helpful debate, but a kind of really familiar debate too, I have to say, around some of our young people who are probably not diagnosable with mental health issues, but have really significant and complex needs, and kind of hearing those challenges that we're knowing about here. And also talking about there, because the reason I was there actually was around SEND, so I lead SEND for the region, and a real challenge around how we understand the need now, with everybody having such lengthy waiting lists for neurodiverse assessments. How do we support families getting the help they need prior to or even without a diagnosis? And the only way we can do that is by having these much more integrated multidisciplinary teams working together earlier, so that we can actually move that through. We can continue to try and build diagnostic services till the cows come home, but what we know is that we're not going to be very successful with that. But we know that these families still need that multidisciplinary approach to their children's requirements, whether that's around SEND or around disability or around longer life challenges. So I think the requirement for us to do this has got louder and louder, not quieter and quieter. And I think we all understand that. And I think some of that, Jane, as you say, has absolutely put fire behind us in terms of we've got to get this done. And I know that we're all passionately in agreement that it's to get done. And we are very keen to organise ourselves into the best possible way for that 0 to 25 piece, and really making spaces and places. And I think that'll even come down to the structure chart that's proposed will have grey spaces in it, so that those grey spaces can be occupied later when people are ready to align to that. So, just wanted to be completely transparent about that.
Yeah. Trisha.
So there's a few things going through my mind actually when I read this paper. I think we keep saying language is really important, and we keep saying how can we make sure that health is aligned with this. And I think in reality we need to take a step back in that we've all agreed collectively as a system the 5 pillars of the 5-year forward plan. That's the implementation of our ICP. So it's more about how we all get our work programmes aligned to that. Otherwise, we're going to find that we're going strategically in different directions, which is not good. There are 2 or 3, at least 2 pillars in that when Neil comes on to go through the detail, which are about children and young people, and particularly focusing on mental health and complex behaviours. So, because we know that in Dorset, as an example, the biggest reason for premature death of our children and young people is suicide. So there's something we need to think about how we place this work in the context of that plan. I think we've got a lot of work to do in health around paediatric services, around long waits that are inherent across all of health services at the moment. How do we bring those waits down to a level where they are responsive to the needs of children and young people? And we also need to think through what we do to make sure our transition services are broader, wider, deeper, because they're not where they need to be in lots of areas. And in some of our providers, we've only got transition services in an element of paediatric service and not across the whole service umbrella. So we need to think really carefully about that. You probably know that there's a directive to the NHS that it must implement the Oliver McGowan training in terms of SEND. And I think we need to have a broader conversation about that, particularly in health, because I think we are, like lots of things that are directives from the centre, we're thinking about that more from a transactional perspective, as opposed to how do we support our staff to understand from one human to another that when you've met one person with autism, you've met one person with autism. And actually, lots of the time when we have issues with challenging behaviours is because we as professionals are not responsive to the individual and the environment that we create, which is all geared towards keeping that person safe, actually exacerbate their complex behaviours. So we've got a lot of work to do in that space to help people understand that intentions might be good, but the impact is not always. And then we've got the mental health transformation programme that David is the exec sponsor for, but in reality that's been driven by Dorset Healthcare, and we need to think about how that dovetails into the work of the 5 pillars and this. And then the other thing that's going through my mind is we're just working through how we launch the work on that is needed on integrating community and primary care, and as I said earlier on, the later addition of social care into that environment to create integrated teams with a single purpose. And we need to think about that work is currently focused on the older population and frailty, but in reality it's going to cover the whole spectrum. So we need to start to think quite early that that'll be a 2 to 3 year programme, because it requires a lot of not just transformation but cultural change. And if we're then going to broaden it out to the full spectrum of servicing children and people, then we need to think about that very early in that process as we iterate that model going forward until we land something that everybody's comfortable with in terms of a way of working and it delivers the outcomes that we want to see from it.
I can feel lots of nodding at Claire, I think. Oh, there's a really interesting audience. Did Sam?
Just a practical question from me. Given the previous conversation we had about the BCF and developing some local measures, could we do some work on trying to understand how we would measure the impact for a child or a young person going through this pathway? If we're getting it right, can we actually start to measure and track some of that progress?
I mean, I think my understanding that Claire, did you want to come in on? Okay.
I think that's really helpful, Sam. Hi, everybody. I'm Claire Shields. I'm the Corporate Director for Commissioning and Partnerships and have been working alongside colleagues on this programme. We have got some metrics already in place about what families have told us is important to them as they move through this journey, and some of those statements within the paper that we're calling I statements, so the things that we know that are important and will help us understand experience and outcome and impact. And there's other tangible things just in terms of how quickly we're getting to people, whether or not we're meeting their needs, and actually whether or not we're meeting their needs earlier in terms of how we're spending, the types of packages and support that we're offering. So lots of framework already in place to manage that, and I think it will be important to just keep coming back to that and seeing if that is working for us. And the other element I think that's really important is the experience of carers and what that looks like, and linking back into the Better Care Fund and what that looks like. One of the reasons and ambitions for Health College element of the Better Care Fund is to being able to land this and thinking through what that means for our carers as we move forward as well. So I think really, really well connected in terms of those multidisciplinary teams and moving those programmes forward. Absolutely welcoming that transformation and reach up to 25 and a whole range and spaces of health services, and some good conversations with Dorset Healthcare and Dorset County Hospital about what does that mean and what does that look like in their transformation programmes that are alongside. So definitely really important bringing all that together, and lots of conversations happening to how we simplify some of that work and governance in place to make sure that we join it up into the right places and make sure that we're doing everything at the right pace. So yeah, really important, Sam, and Patricia, your point as well about how we're making the most of everything that's already going on and phasing and sequencing. I think it's important as we move forward.
I think that's right, and I think there's something about us getting hold of those 5 pillars, understanding which of them relate to children, young people, and trying to create one programme of the work that may have a number of layers, so that we don't end up getting confused about the direction of travel that we're taking. And we've just done what we'd call the sprint phase of trying to get the meat on the bones, as it was, and trying to determine what are the aims that we're agreeing with community. And I think there's something about pulling all of that work in now to understand what are the different layers of each of those pillars and where are we heading years 1, 2, 3, 4 and 5. And I'm really in favour of hard measures and soft measures, because I think we can sort of fulfil the requirement of the regulators and spend too much time on the hard measures actually. And, you know, one thing I really like about the Greater Manchester system is that Andy Burnham talks a lot about the soft measures actually. What's important to children, young people? If you survey them at 13, do they have hope for the future? Because actually if they don't, they're not going to stay, they're not going to be productive members of society because they've not got the right environment to flourish, and that's what we're...
No, I agree.
Thank you. Thank you for this. I've, you know, having worked in hospitals for a number of times, just and seeing my children go through that period where you get to your 18th birthday and all of a sudden you're an adult, and your services switch, your relationships switch, and all of a sudden you're a different physiological and emotional beast. It's really, you know, good to hear the sort of programme that actually recognises that that's not reality, but it's just what a construct that we've set up to help us organise ourselves and our budgets. So thank you. I guess my ask is, and myself and a number of clinical colleagues, based on some recent quite complex and difficult cases and individual patients, have been trying to work out how do we look after there's the 95% of people who fit in here, and then those half a dozen or so children or young people in our county for whom we don't have an answer. They don't fit neatly into what we have to offer. Their needs are so complex, their experience is really poor, and their impact on the system and people around them is so significant that it's just making sure that this makes sure that it doesn't get it right for the 95%, but actually we've got to work out that we get those small number of individuals are incorporated in this, and we manage to, and that's where that health and local authority alignment is going to be really key, because often they bounce between the two or they sit between neither, and that's really difficult for them.
Can I come back on that? Because I as you were talking, I visualised or certainly hear the names of 1 or 2 young people that I'm aware have become trapped in hospitals, really, because we've not previously been able to function across that health and social care arena. And I firmly believe that if we get this right, that's exactly the target that will benefit the most from this, because we'll spot them early. We will have an absolute commitment across all the systems to work collaboratively and break down some of those historical barriers, which meant that people have been shunted between children and adults and between adults and health. And so I am optimistic that we won't be having the same conversations about those individuals in quite the way we are now in 2 or 3 years' time. they will still be complex in their presentation, but we will, I hope, be much more mature in the way we behave with each other in that problem solving approach, and also that joint and integrated commissioning approach that we're taking, so that we're forward planning some of the solutions that we need that we don't currently have in the market now.
Any other comments? Well, I'm very glad that I did put this on the agenda, and I think it's a good conversation, and it's going to continue for some time, and I think that's the thing to be recognised. We will come forward with a plan and a way forward, but it will be constantly evolving as all partners join in, align, continue to do those pieces of work, and those relationships and those networks start to meld together. Not that they aren't melded, but in different ways. So I'm pleased that there is a recommendation, which is just to support the approach to the programme, which I would hope that we have that from everyone. Thank you. I'm sure we'll be looking at this again in different, certainly in different spaces. It seems to be falling into so many areas now within the council, for sure, and it's popping up in all unexpected places, so it's beginning to filter through, so that's very welcome. So we now on to agenda item 8, the NHS Joint Forward Plan, which is going to be presented by Patricia and Neil.
Thank you.
Are there slides?
Neil's got a set of slides. Do you want me to just introduce the item for you, Neil? Or?
Thank you. Yeah,
If you want.
we don't have slides. We've had the report, and
We've got a report in the pack. Yeah. So the 5-year forward plan was a requirement from NHS England for all integrated care systems to submit at the end of June. It was meant to only focus on health, and as usual, we did something slightly different. So we did satisfy all the requirements of the regulator, but I did have a conversation with the region to say that what we actually wanted to do was a whole system look at the ICP strategy and actually how we're going to pull out objectives that we would work towards. So we were not doing 2 implementation plans, and they were fairly comfortable with that. So that's effectively what we've done. Sam is still leading on elements of the ICP strategy that are more focused on the whole engagement piece, the co-design approach with communities, keeping them engaged. And what we've picked up to lead on with partners is what are the actual key deliverables over the next 5 years. And you'll see that when Neil runs through those, some of them go beyond 5 years. And the reason why we all, as partners, chose to focus a good part of the plan on children and young people is because we recognise that a lack of attention to Marmot's review 20 years ago and enacting his recommendations is a significant part of the reason why we are where we are in terms of health and care spend. And so we wanted to make sure that a significant part of the plan was focused on children and young people, so that we make sure we're setting the foundations together as partners to create healthy communities for healthy children who then live long and healthy and happy lives. So I'll let Neil take you through the pillars and how the plan was developed. What we're currently doing, as I said, is working with everyone to try and agree what the outcome measures should be that we'll be measuring, and how we pull together the transformation teams to do sort of the hard yards of the work. And then hopefully when we've concluded that piece of work in October, then we will be ready to step on the go button and start to see some progress fairly quickly.
Thank you, Patricia. Neil Bacon, I'm the Chief Strategy and Transformation Officer for the ICB. And firstly, I'd like to just sort of come here with a real genuine humbleness. I'm really aware that not just myself, but the ICB, by definition, are new to this world, although many members of the ICB have been in this world very long, but very aware that this group and many groups in the council and other bodies and voluntary bodies have been working at this tirelessly for many, many years. So I hope none of this comes across as sort of sucking eggs or we told you. These proposals are built on and sort of very much secondary to the hard work that's already been done, the expertise that is in the council, in the community, in the voluntary sector, as well as the health part of the council. So I present this plan for improvement and criticism and challenge, all of which is very, very welcome, because I'm very clear, and hopefully it does come across in the report, and we're all very aware of it, that no single part of the system can address the challenges and improve the lives in the way that we all passionately want to do. But working together, we can do great things. So hopefully that comes across in the report, but I can't stress it enough. As Patricia has said, the aim really is to create a plan that will deliver the strategy of the ICS. So strategies are great. We're particularly lucky in Dorset to have a great strategy. And again, the architects or the midwives of that strategy are in this room, as well. Some of them are in the room. And again, thank you for that, because writing an engaging plan that is both ambitious, but is also realistic, pragmatic and achievable depends on a great strategy. So again, it's built on that before we even start. And I'm very focused on the fact that it should be a plan. We didn't want something that looked a bit like another strategy. So when I come into the objectives or the 5 pillars, we've been very specific. This is what we'll do. They are specific numbers. They should be SMART objectives. They're not quite there yet, but we're on the journey. But again, we've tried to put and actually had great support across the system for numbers that we can hold ourselves accountable for and that we can be held to account for. You won't be surprised to hear, having read no doubt many documents of similar type, they often end up with the best intent in the world saying we will make Dorset the best place to live, or we will ensure that every child has a fantastic start in life. All well-meaning and true, but they're not SMART objectives. They're not things that you can really work out after 5, 10, 15 years whether you've got there. More importantly, I think it can be very hard to know whether you're on track for such things where they're not specific. We've tried to create a plan where we will know entirety as a system, as Dorset, whether we're on track, and if we're not, we can recalibrate and change. So I will keep coming back to this, the sort of fact that there should be very smart, specific outcomes. With the proviso, I don't think we're quite there yet on getting them smart enough. There's 2 other things that I'd say before I walk into a little bit more detail. Again, hopefully it comes across from the document, that we've made prevention an absolute bedrock. Again, we have to make our actions follow our words, but so often, and we've all seen this, and I've sort of spent, similar to many people here, sort of 30 years in and out of healthcare in different formats. Prevention is always talked about. The head, the heart always knows that prevention is the right way, or maybe it's the head. But for some reason, it always gets pushed back. The urgent needs of today relegate the important needs to tomorrow. And as Patricia said, many of the situations we're all challenged and grappling with, both in the health system, in the social system, and indeed sort of our colleagues and our citizens and all of us in Dorset are grappling with, are the results partly of decisions that weren't made to prioritise prevention 20, 30 years ago. I appreciate we all know that, but we've really tried to make prevention. What will this do to change the lives and improve the lives of the people in Dorset, rather than just helping us cope better with the problems we have today? And the third aspect really that runs through it is very much a population health approach. As Patricia said, and one of the reasons I think the ICB can be part of something that's different is we're not just focusing on health. And you know it better than I, and I feel really humble coming here saying it, but apart from anything, there's not enough room to build any more car parks or any more hospitals. So even if we had the money we want, and we could meet this inexorable rise in illness and ill health, we couldn't do it anyway. But more importantly, it's just the wrong thing to do. Yes, we can treat illness, but we can prevent it. If you prevent ill health and you promote wellness, you give people happy, healthy lives rather than just being better at coping when their lives go off the rails. Again, I'm conscious that I speak to people who know far more about this than I do, but hopefully you'll see your words and your understanding reflected in a plan, which has to be so much more than health. You'll appreciate the way the plan was developed, and I hope, and in fact many of you were involved and many of your teams were. We worked very hard to understand what the communities wanted, what people want in Dorset, what is important to them, not a paternalistic approach to say we know the answer. Also, what colleagues working in health and social care and the voluntary sector are important to promote wellness and essentially make Dorset a great place to live, rather than just a great place to get ill, which I know sort of sounds a bit trite, but that's, I think, many plans you look back over the years, that's what they've done. Data, really making sure we're data driven, and that doesn't just mean the super real-time data that we have from DICE, the feeds that come through, but also working hard, and we've only just started to analyse that data, so again, to use the expertise you have in a sort of Dorset-wide public health system, but also the business, the insights, the analysts that we have in the healthcare system, to make sure we don't just go, it's in 2023, we couldn't go out on a wing and a prayer. This has to be data driven. And one of the things we hope we can add to and support is that Dorset will be a place where we make our decisions based on true data, true insights that gets us ahead of the curve, both in where we can have the biggest impact, where we can best spend our money, where we can best target our resources to reduce those inequalities, to reduce the areas of deprivation. And we do have fantastic insight. And I think one of the challenges we place to ourselves and others will place, so you've got fantastic data, you've got a fantastic insight system. Are you really using it to world-class effect? And that's something we sort of, I wouldn't quite say wrestle with, but it sits on our shoulder because it's a responsibility. Once you can see, as we can, you can see the future, you can see who is going to get ill in the next 5 years, who is going to end up on dialysis, which groups are most likely to have children who are suffering from obesity. We have a moral obligation to use that data and that insight in a far better way than I think than we've all been able to do in the past, and we should be world leaders in that. The joint strategic needs assessment obviously feeds into that in a very powerful way, and thank you again for people who've built that up. We've also tried to look at what might happen if we do nothing. So, and it's great because we got the data. It's either deeply depressing or deeply motivating when you look at what happens if you do nothing. So it either inspires and motivates us for the things we have to do, or it is deeply depressing. For example, when we look at the outcome or the objective of saving or preventing 55,000 children from being overweight, that comes from, and again, Jane and Sam and colleagues have done the work for us. We know from the trajectory, it's a fact that if we don't change what we do and do things in a different way, nearly 50% of children at age 11 will be overweight in Dorset. I mean, this is sort of by 2043. Yeah, 2040, thank you. So we know that's going to happen. So it's hugely motivating. That's the shape of the curve. So when I talk about specific objectives and outcomes and measuring it, we know that's the curve. We've said we will save 55,000 children from that, which will be a significant change. I mean, that will be world class. It's not just sort of leading nationally to do that figure. But if we don't, 55,000 children will be condemned. I think that's the right word, to all the things that we know that result from being overweight and obese. So we have a awesome opportunity and a huge challenge, and these things go hand in hand. So to clarify really, and hopefully again it comes out, our vision is to make Dorset the healthiest place to live, a place of well-being. We will prevent illness and promote well-being and wellness. We will ensure that those that do end up needing help, whether social, medical, mental health services, are able to access care where and when is needed, meet their needs. But most importantly, underpinning this, it's about empowering and creating the communities which enables people to have the best chance of living those lives. Again, even as I say these words, hopefully it comes across, this is a system-wide challenge and opportunity. The ICB obviously wants to play its part more than, and healthcare, but we're not going to solve the problem by doing more of what we do. We won't even solve the problem by being better at what we're doing now. Not that those things aren't important too. So the 5 pillars, which you've seen, and I will say, I don't like reading slides, but you've got it in front of you. So, sorry, a question, thank you.
Yeah, so Simon Raw, I chair Dorset Community Action and really here as part of the voluntary sector. Just wanted to kind of pick up on the language you were using there. And you were talking about 55,000 children being overweight. I kind of very much welcome the way you were talking, etc. But should we be talking about children and adults being the right weight rather than, because there is a significant proportion that are underweight as well. So if we put purely the emphasis on the overweight, and that's as unhealthy as being overweight, But by the way, I equally like very direct conversations where the doctor says, Simon, you're overweight, you need to lose some. So, I'm not an apologist for any of that, but I just wonder if we're missing those that aren't in the right range.
Thank you very much. And if I may respond to that, it's really interesting because one of the team came back to the ICB and said, this is a real change. We've spent time when we look at safeguarding children, looking out for the children who are underweight. And this shift to saying, hold on, we've got just as much responsibility for looking out children is a shift. And I think you've highlighted it, that when the benefit of having very clear, specific aims is it focuses the mind, but we need to make sure that under that work, we don't lose other people. So I'm going to come back to that again. But thank you for the point of we need to be direct and clear, but we really need to be careful we don't drop people through the gaps of our objectives. So can I carry on? But that's a really important point. And so I'm going to bear that in mind as I go through. So the first objective was to improve the lives of 100,000 people impacted by poor mental health. Having made a big noise about specific clear aims, I'm very equally clear that the word improve is too soft at the moment. Our colleagues across mental health are working to define what that will be in terms of numbers that we can measure. But again, the scale, 100,000 people, you'll appreciate in a population of 820,000 is a significant number. That target, that specific objective was very much built up, not just by the mental health professionals, but by the community of users and service users themselves as well. So the second one, we will prevent 5,000 children from becoming overweight, but that's where we've got 2040. So I'd just like to emphasise Patricia's point. This is a 5-year plan, but the problem with 5-year plans that only think about 5 years ahead and aren't really building the foundations for further is you never get into the big issue. We're not going to be able to meet that objective in children in 5 years. So we've really made sure we're building foundations for long-term health and wellness across the system, rather than the short-termism that's essentially defined to us by politicians and sort of NHS England. But we might come back to that. But we really want to have a longer-term generational change rather than just something that's tied into an election cycle for Westminster or similar. The third one is to reduce the gap in healthy life expectancy from 19 years, 15 years by 2043. Again, those who really know about this topic will be like, oh, that is a huge objective. So I have the benefit of not having the expertise to realising quite how reaching the objective is. Again, it's not that I don't think we'll reach it, because people do reach incredible objectives in certain areas. But if we get most of the way there, we will have made a dramatic difference to huge numbers of people. And we do think we shouldn't already start watering down objectives. It's possible, but it's very, very hard. But even the journey will bring so many people up. That partly goes to your point, Sam, and I'm not trying to fudge an answer where it's not the quite thing, but as we reduce the gap in healthy life expectancy, as we focus on making sure children get the right appetite, the right dietary advice, the right support, right exercise, we are increasing the health, not just of those people in the target, but the people around them. Now, I appreciate there are people in very specific groups where low weight is a particular challenge, but to prevent 55,000 children from being overweight, we need to make sure that every child in Dorset has a great start. We're giving the support in breastfeeding, we're giving the support in early years, we're looking at free meals. So for all these objectives, there is a sort of rippling out effect for many more people who are affected or benefit, I hope. We will increase the percentage of older people living well and independently in Dorset. I remember well now the conversations that Jane and I had about how are we going to measure this, and that work is being done. I thought, in my naivety, it's so simple. Surely we had a conversation just to give a little bit of flesh how these are developed, that surely it's the percentage of people that don't need council support when they get older for their living. And then it's pointed out that Dorset being Dorset, well, far more people pay for their own private care than get support from the council. It probably doesn't feel like it to you as you watch your budget, but it was just that refinement. So we're getting into that thing. Well, actually, this is one where that metric we'll probably end up calling it something very clever like the Dorset Independence Scale, but it will be about falls, strokes and fractures, that sort of combination. So bear with us as we refine that, but these things. But again, hopefully you can see that whilst those people in the direct line of benefit, there will be a whole hinterland of other people who benefit. This aims to increase the activity, the social support of older people living in Dorset, because, again, you all know these are very complex issues. And finally, but not least, we will add 100,000 healthy life years to the of Dorset by 2033. I have to confess, initially, sort of, what are we going to do? We're going to add 100,000. We're going to save 100,000 people from early deaths in Dorset. That sounded a nice round figure, he said, after sitting on Golden Cap with a sandwich. And then I thankfully saved from the observation that only 5,000 people die in Dorset every year in total. So that would have taken 20 years if we'd stopped everyone dying. So again, the benefit of having excellent colleagues, a really, really good and really challenging number. Healthy life years is a very well-defined health metric. And you'll see again, the target there is 2033. These are long-term benefits, but adding 100,000 healthy life years to the people of Dorset by 2033, again, will affect huge numbers of people. And it really comes back to the point of Dorset should be a great place to be born, to grow up, to live, and ultimately to end your life. The other final thing I'd probably point out in these is that you'll see they all cross-reference within each other. To achieve the last one, we have to do really well on the fourth and the third. To achieve the first, we have to do very well on the second, and vice versa. So although it's quite nice that they stand independently and people can, as Patricia says, we're now doing work to put work streams below the pillars across the sector, the voluntary sector, businesses, we haven't talked about much here, but this is as much a part for business and local enterprise to play its role in, as well as local authorities, and finally health. The work streams are being put below these 5 clear pillars so that we've got a concrete vision of what we're doing. Concrete's not the word to use, is it, this month? But a strong pillar of local stone. So the work now is to really make sure we continue to co-design and co-create and make sure that people really do feel we're working on this together. For example, it's very clear that we are going to have to be at least national, if not international leaders in how we really work with the voluntary sector as true partners, not an add-on on the end. So you can see in all of these, health potentially has a relatively small part to play. So that's why I'm a bit conscious. We've done all our time preparing our report, and then are saying, but very conscious, this is hopefully a roadmap that we can all follow with the improvements and the changes we need to make, but a map that we can all follow as a system. I'll stop there because I'm sure the questions and the answers will be more sort of useful than my speaking, but I would really thank all those who've contributed and made this possible, all the improvements that no doubt you're about to make, but all the work that's going to come to turn what was a plan, so that when we look back together in 5, 10, 15 and 20 years, say, this plan did have a role in helping the work that's already ongoing. So, Chair, thank you very much.
Thank you very much. Comprehensive presentation. So, are there...
Thank you, Neil. I think it's a good plan, and I'm glad that we're finding the right space to see this more as a sort of delivery plan with the programmes and the hard metrics in it, something that we can measure as opposed to the ICP strategy, which we're trying to say is much more about long-term culture change and how we know we're working different. So I absolutely support that. And we had a good workshop this morning where we're going around how we're going to differentiate the work and make sure there's that space between them. I think the point about the measures is really important because they're not easy. When you were talking about the measure around supporting more people living with mental health conditions to have an improved life, I guess we could go in several different directions. We've had quite a long-standing debate, I think, in public health about what does mental health prevention really mean? Because if we're honest, there's not a great evidence base about how you can reduce the prevalence of long-term mental health conditions. What we do know is the impact of some of the risk factors and the wider determinants of health on your chance of developing a mental health condition that's significant, particularly as you go through your later teenage years. I think it does need thinking about and unpacking. But a couple of ideas, if we had a next level to these measures, you might start to think around, we can measure some of the softer things about how well people living with a mental health condition feel about whether they're included in decisions about their care, for example. And if you look at some of the national metrics at the moment, that's very, very high for people living with cancer, but it's only about 50% in people on mental health pathways. So there's room for improvement there. And I think also if you started to look at things like the number of people or the proportion of people in our local areas who are living with a long-term mental health condition who are in stable and appropriate accommodation, it's about 35% from memory across both council areas. So again, if you think about improving someone's life, providing them with a stable, suitable, good home that is a home, rather than just accommodation, which, as we know, can be very, very varied, could be could be transformative for that person. So I'm really looking forward to the next round of debate. But I guess we need to keep our minds open rather than just driving for something just for the sake of the plan.
Yeah.
Teresa.
Thank you. Really helpful. Really helpful. Thank you, Neil, and thank you, Sam. I guess there's something for me about social mobility and really thinking about how we make sure we understand that too, because it's a real challenging area for us in terms of being absolutely in the very bottom space where we wouldn't want to be in terms of the country around social mobility in this area. And what we know, so the indicators for adults is really about loneliness, young people about kind of that soft stuff around friendships, and for the very youngest about having really good school outcomes naturally. But in a highly academised region and a very increasingly almost completely academised local authority area, that requires a very significant challenge for us. So our educational outcomes aren't where we want them to be. Our school readiness outcomes aren't where we want them to be. And our social mobility outcomes for children certainly aren't. So there's something for me about where we can have influence, because we haven't got the power over academies clearly, as you will understand, is about having that cultural change about inclusion and belonging. And I think we'd kind of really want to see some of that kind of concept coming through, because that's the only way we can really have impact upon those levers. You know, the reality is we can do a whole range of things around the system, but we're not running that part of the system. And the bit I think we can really focus on is that big cultural change piece, and really making sure that we're calling out and being ambitious for good outcomes here. We've got low wages, we've got, there's so many of our indicators that are actually for me about a lack of ambition and demand and expectations. So I'm making that kind of shout for the cultural piece.
I think that's really important, what Teresa's just said, and that's I think why Neil said, health is a small player in the delivery of this plan. We know that only 20% of anyone's well-being is impacted by anything that health could do, but health does have a role to play in terms of the wider determinants and social value and how it contributes to that agenda properly and not sort of piecemeal, which is what we're doing now. The social mobility piece, I think, is absolutely key. We know that, if you have decent employment for a lifetime, and you then have money doesn't buy you happiness, but it buys you freedom around decisions, it can make such a massive impact on your ability to live a long, not just healthy life, but happy life. And in Cheshire and Wirral ICS, they have managed to pull business into conversation with them, looking at the sort of work that our ICP is doing around what does it really cost to live in parts of Dorset, and agreed a minimum wage that people are going to pay, which is an actual living wage, not a government calculation of a living wage. And we need to really think about that, because we do have a low wage economy, and that is not just because we have seaside and hospitality. A lot of our businesses have very little competition for workforce and pay incredibly low wages. And they're not wages that people can live on, have any social mobility, or even own their own home or have a reasonable standard of living. So we've really got to get underneath that. And when we talk about the areas where we want to raise the level of healthy life years, we also know that if you live in the top 20% of deprivation, it's likely that you're spending somewhere around 3/4 of your weekly income just to eat healthily. We've got to change that. And again, that's about what we pay, it's about social mobility and how we create thriving economies that have the right kind of jobs and the right level of pay thresholds. That means that household wealth is starting to improve. Otherwise, we're not going to make any inroads into some of the areas that we need to. And we don't have direct control over our schools, we don't. But we do have an area schools partnership. And we need to think more about how we influence that partnership to do some of the right things that we want them to do, and not some of the things that they might be doing now that are not helping the journey of young people to successful lives.
Strong point. Yes.
Yeah, actually, touching on some of the stuff you mentioned there, Patricia, I think when I looked at, I liked the report and I read it in detail, which was good. And I like the intent of it. I had a couple of questions on the focus of it. And one is, it picked out three geographical areas to focus on. And they all were similar, had similarities between them. But I just wondered about our rural communities, because they're not large in number. We talk about the living wage and the cost of living, but actually, if you're on a very low wage out in a rural community, you need access to healthcare, you need a car, your heating's probably dearer than it is elsewhere, those kind of things. And so I was interested to understand why why there was nothing more about our rural community, because whilst the population might be relatively small in number, they're a very important group within Dorset. We shouldn't leave them behind, and their needs are going to be very, very different to those living in Boscombe, for example, or Weymouth, and etc. And actually, the amount of money they need to live on will be different as well.
I think that's a really good point. And if you look at deprivation, if you live in an area that is completely deprived, like Boscombe, you're actually probably better off than if you are poor and live in an area that's fairly affluent. So we've got to get on top of that. And I don't think we have landed as a system on the areas we're going to focus on around healthy life years. I think we've still got a debate to have around that. Because as we move forward with the work on integrating the out of hospital teams, I think we need to think through that we have a concentrated package of measures that are in one area rather than doing a bit of this in there and a bit of something else over there. So we can really do a proof of concept of what we know works around supporting communities, but also enabling them to be self-directed around what they need and actually being full partners in decisions about how we spend public money. So I think the rural aspect is really important. And one of the things that Paul's working on from a health perspective is the development of a clinical strategy. And we've been really clear with our partners to say that what we expect as part of the commissioning agenda going forward is, one, we'll only commission for outcomes for the community that we agree with them, not numbers of activity because they're meaningless. It's great having access targets, but actually what we're more interested in is, do those targets lead to good health? Because if they don't, then we've got an issue. We've also said to them that when we move forward together to transform our services, when all partners need to be involved, we should be looking at an end-to-end service model, not an element of it. And in that end-to-end service model, that there will be commonalities within it, but when we get down to how that gets delivered and where it gets delivered, that's where place leadership comes in, to understand its communities best, work with them on what they need, and then agree locations of service that get the best access for those communities. And I think when we get down to that level of conversation, that'll be where rurality and the seaside comes in, and we start to think about where those locations of service need to be. And when Neil talked about wanting people to live independently, I think there's just as big a conversation about social isolation, as Therese talks about for young people, also for older people. Because again, we know if you're isolated, it leads to long-term conditions because it leads to unhappiness, and we don't want that either. So I think we need to be cognizant of all that detail when we get down to the place conversation and the delivery models and how they differ depending on the communities and neighbourhoods that we're talking about.
I totally agree. I do believe that everybody should be able to talk to somebody once a day.
They should. And I grew up in a city, so I never really understood, and I think this is a real challenge across the whole of Dorset, Bournemouth and Poole, is that for some of our colleagues that have only ever worked in an urban area, they have no understanding of what it's like to live in a rural community. And I only knew 20 years ago when I moved to a village in Bedford and then thought, oh my word. And now obviously I've carried on living in smaller, more rural places, but I think there is a real lack of understanding in this idea nationally that you're willing to travel for something that's really specialist, and now we're watering it down to you're willing to travel for almost everything if you're going to get a good outcome. It's not realistic. We saw that with vaccination. We agree a PCN as a practice as a vaccination bit, and then we wonder why the most deprived people that live around it are not turning up for vaccination because they can't afford to get there. So we've got to think very differently about how we meet community needs.
Can I just comment on that as well, Sandra? I think that, so what my daughter pointed out, I'm an older person living in a rural community, which I think she didn't mean kindly, because I do live in a rural community. I'm proud to be. But I think it highlights the point that we need to shift our focus and our thinking more into the voluntary sector as the answer, because it's no good having a big shiny hospital somewhere. That doesn't. It's about, as you say, loneliness. Living alone, being lonely is like smoking 15 cigarettes a day in terms of the impact it has on people's health and inflammatory markers. So I think you highlighted again why it's going to be a real shift in how we do this. It's about communities, and communities supported by the voluntary sector as much as. So I think that's absolutely point. And I think the fact that we've got living well and independently, healthy life years is really, really important. But you're sort of highlighting the same point. We mustn't, by focusing on this group, miss other groups. So you've really reiterated your point. It's really clear.
It was the second point. By the way, there's a great little initiative going on between the local PCN around Sturmis Newton, Dorset Council, and DCA around discharges at the moment. So that's a great example of a community initiative trying to make things better. Whereas the focus on reviewing the strategy, and I've got the words wrong here slightly, but for women's health plans or etc. And that was done in the context of additional years. Now, I wondered where that came from, given it's data driven, because across Dorset, men tend to have 4 years less life expectancy. And I'm very aware life expectancy and healthy life are two very different things. And even at the age of 65, women still tend to have 2 extra years of expectancy over and above men. So I absolutely thought it was a great initiative around reviewing the women's strategy. That was good. I just wondered why it's silent on men when we're talking about healthy life and life expectancy. And we've got, additional suicide rates, high suicide rates amongst men, things like that. And so this wasn't in any shape or form saying let's not have an initiative around women. Let's say if we're fact driven, wouldn't we have one in there around men because we die quicker sooner?
Do you want me to answer that, or do you want to answer that?
I think so. So I think there are health conditions that are very specific to one gender or another, and there's some that are obvious. Some have prostates, some have you, and so you have to design services in those aspects very specific to individuals. I think when you're coming to things, such as suicide and those sort of things, and mental health, what we need to do is we need to design services for our population. And if we start splitting up into gender, I think what we do is there's a risk of fragmenting it. There are particular triggers that are more prevalent in men, but aren't purely within men. And I think just because something is more prevalent in one gender or another shouldn't direct us down a line that has to be gender specific. I think it's where conditions are exclusively within a particular gender, and you may have seen the National Women's Strategy does really focus on particularly those things that are exclusively, within women rather than men. So I think that's where the subtle difference is.
Well, to be clear on it, it's not me splitting it out into gender. It's the plan that splits it into gender.
Yeah. It does, and that's in response to. Partly in response to the development of a national women's health strategy. The reason why that strategy has been developed is because there are not just very specific health conditions that relate to women, but there's also an impact from those health conditions not being addressed appropriately by health. Means that there is an impact on the wider economy that is quite significant, and that's why that's been pulled out of by the Department of Health. Because there is a lack of understanding about issues that affect women that are quite serious. So it's not just about, things like particular types of cancers. It's about the fact that we have very little understanding of the menopause in the NHS and the impact that has. So when we talked earlier on about fractured neck, there's significant impact on women post-menopause because their bone density reduces, and then they're not they become in a more frail state. They're not able to contribute to the economy effectively when they get older. There are issues with the NHS not understanding some of those really female-specific issues that need to be dealt with, and how women can access services, but be confident that the people that are supporting them in those services understand those issues that only relate to women. What Paul has done as part of being the sponsor for that work is, rather than us has honoured the principle that we've set up, which is before we develop a solution, actually we co-design it with the community. He's gone to our third sector women's networks and said, actually, how do you want to respond to this? Because as usual, the NHS has said, bolt something on to the end of a service, so we're multi-layering it. And what we've said to them is, actually, how do you want us to respond to this? So now we've got a completely different response, which is not in line with the national response, because we're responding to what women in Dorset actually need, rather than designing something we think they need. So that's why we've got that gender-specific response, because there are very specific health conditions that only relate to women that are not being dealt with.
I do understand that, and you can't be anything but supportive of that kind of initiative. I still go back to the point, and maybe it's in the context of adding healthy years, because in a wider health conversation makes perfect sense. But if you look at healthy years, if you're saying that because of those things, women actually might live longer, but have a shorter, healthy lifespan, that makes perfect sense, and that's data driven.
Yeah.
But otherwise, it's not data, and that's the bit I was getting myself confused about. Okay. And it still doesn't seem entirely logical to me. But
and that's what we're saying. That's what we're saying. Women may live longer, but they have a longer period of ill health because of those issues not being dealt with.
Thank you.
Thank you, Teresa.
Yeah, I don't want to labour the point, but I also think it's kind of worth remembering that even if they did live longer, we might need to be particular about certain things, whether that's race or gender or other things, in order to speak to those communities. And I think there's something about, particularly when we're coming from an inequality space, we do sometimes need to differentiate, even if it seems, as you say, counterintuitive. But there is something about when we haven't been speaking to the right people, when women's health hasn't been well researched around medication development and things, and therefore some things are particularly problematic. I think sometimes we need to differentiate in that way.
Sam.
Yeah, thanks, Jane. So, slight change in the conversation. I was just going to go back to the plan and the scope of the plan. Going back to the comments that were made in introducing the plan and the point about prevention and inequalities, and if we'd done some things 20 years ago, we might not be in this unsustainable situation. There is another side to that coin as well, isn't there, which is the growth in cost of healthcare technologies and our poor understanding of value. So it's just a question about where some of that work, which I know you feel really strongly about, Neil, and obviously we've been starting to do some work with Muir Gray around where that might start to be surfaced in our system, because I do think is another really important side of the debate, how we're using our scarce resources and not missing out on the opportunity cost of using that money differently. It's really, really important.
Sam, are you being specific around technology in a prevention arena?
Not so much in a prevention arena. I just mean that
clearly
there's been there have been some amazing advances, and it's not to say that they're not important, but one of the side effects is that we do more and more for our population at increasingly older ages without necessarily challenging ourselves to say, is that always necessary? Is it always the best course of action? And if you just look at the growth in specialist medicine over the past 30 years, it's been huge. And there's sometimes not that much control that health systems can exert, because when national organisations say this drug is now cost effective and we expect you to prescribe it and make it available in your population, it's keeping track of all of those developments and whether we're really maximising the value from our use of local resources. I don't know if I've explained that very well, but
no, I think you have.
I think you have.
We have this debate constantly, obviously, in the commissioning side of the organisation. I actually think we need an honest debate with the public about what the NHS is here to do, and the fact that we're not having it says more about us than it does about the public. I think they are more than capable of understanding the complexities that we're dealing with, and that's part of the reason for wanting to move into an environment where communities become more self-directive and engage in a debate with us about what we prioritise actually. Because I think the public are more than able to have that conversation, and we should be engaging them in it. I think that the NHS does a lot of things that it was never intended to do. It at times, I think, can be accused of dealing with wants and not needs. And we need to start to have a conversation around what is it here to do? What's its core offer? What can it reasonably do within the resources that it has? Because the reality is, from a medicine and technological advancement perspective, just because we can do something doesn't mean that we should. And we need to start to have some of those difficult conversations. And I think whether those conversations are being held centrally or not, it doesn't stop us having those conversations locally about where people see the priorities around their health. And as we start to spend more money on prevention upstream, we'll start to see a difference anyway in health outcomes. And we're already starting debates with our health provider partners that say, stop planning on growth every year, actually ask us for some money to prevent it, because that's what you should be doing. Not expecting that we're going to put X number of million into more renal dialysis spaces, as an example, when there's only 2 reasons why people get renal failure that are unavoidable, and we should be working on all the areas where it is avoidable to stop it from happening. And that's hence why we've got a bit of a focus on obesity, because we know when once children get to a certain age and they're overweight, the chances are they're going to be overweight as an adult, and that then we get into all the issues about avoidable type 2 diabetes, cancer, renal failure, all those things that cost the NHS so much money that are all avoidable if we support people to live a different kind of life.
Do we think that these conversations are happening in our community?
Not as often as they should, but I think we need to start having those open conversations.
Yeah.
Because I think once you start having those open, honest conversations, you get into a different place. You know, I remember a few years ago in Hampshire when the austerity on the police force was happening, and they were told that they had to save tens of thousands of pounds, and they gave the public a choice, and it was, do you want all your local police stations to remain open? And they said, yes, we want that. But when the data was shown to them that half a dozen of them had not had a single person walk through the door for 5 years, they said, close them, we'd rather have more police. So it's about how we have that honest conversation that helps people make the right decision.
Yeah. And I know obviously you've been having your 100 conversations, and you want to, and all that wants to be expanded out to, was it 10,000 conversations? But how and who? You know, how do you have the conversation? Who with, where, in what way, on what platforms? People will talk within their own communities to each other very openly, normally on a negative. It's rarely that it's a positive. But they're having those conversations, and maybe the part of the frustration is they don't. How do we go and talk to people? How can we express ourselves? Well, you know, yes, we can go and fill in a form on someone's website and complain about this or complain about that. But what about ideas, views, and opinions that people have? Because, you know, we're the receivers of the service, and we know what we want, what we need, and also what we're capable of doing ourselves within our communities. And there are fantastic pieces of work going on all over the place, but they're not necessarily interconnected, and communities are all different. But if you don't know what someone's doing over there, and it could be repeated over here, that interconnection of how do we have
important. And I think we need to keep bringing ourselves back to what the community told us when we did the 100 Voices, where there were some really clear messages for us then about how they view public service in its totality, and actually what they want from us to prevent them needing to access public service. I think it's probably helpful if Kirsty comes to one of the meetings actually to talk through the plan that she's developed around how we increase the access to communities, and we move that 100 voices to 10,000 voices. But we were talking about it at our briefing session to staff this morning in the ICB, and saying to them, the conversations don't always have to be formal. we all have access to communities. We all live in communities. How do we? There's always opportunities to talk to people about what they want to improve their lives, and there's something about using those relationships to have conversations sometimes, and bringing that intelligence back into the system so we can start to think about how we respond to it.
I'm not sure how this will land, and even if it's appropriate.
That's usually the thing Neil says.
But there's no one here from the locality executive team who are clearly very much part of our community. And so I just wonder how that is going to, what those conversations are with them, perhaps why they're not here. And how that can be, I'm not saying it needs to be improved, because maybe those conversations are happening in other spaces, they're just not here today, but it's clearly an issue within communities around that access, but those are the people who are on the ground dealing with the issues that people are coming to them with on a daily basis. I don't want to put any, I know there are sensitivities around certain things, and I hope I haven't just dropped a nasty little bomb anywhere, Paul. Do you want to?
Well, I feel that as the GP in the room, I better come in and,
other than you,
and respond to that. But I'm not practicing GP within Dorset, so I know exactly what you say. So Martin Longman is on your member, and I meet up with him regularly, and I'll talk to him, and I'll talk to the Alliance about what we can do to encourage their attendance. As far as this work's concerned, the GP Alliance, and which includes GPs practicing within Dorset, are part of our board and have been part of several workshops that Neil and the team have led going through this. And certainly they've been very aware, and they've engaged with their member practices around this and the development of the 5 pillars. The other bit, I think, where they've been really closely engaged, and I know Patricia touched on it, is around the work around integrated neighbourhood teams, which is going to be one of those key vehicles for delivering the neighbourhood specific and the population specific work. And they've been probably more involved than virtually any other part of our system in that piece of work that's been led. So we are in constant dialogue with them. I completely get what you say. They balance the tension between their operational stresses that they've got and have they got the headspace to participate and be part of this. And we're putting some resource in to allow them to do that. And they have been able to be a part of some of those key conversations that in this.
Right, because that's, I mean, I'm obviously, it was obvious they have been part of this, but just felt there was a slight tension, or certainly for me anyway, which I may have just misconstrued. But in terms of, they are absolutely integral in our, oh gosh, in our really drop one. But they are completely integral, vital to our communities. But they're also, they are a vehicle also for getting messages out and having the conversations as well.
Yeah.
I know their time is short. I understand all the difficulties around that, but you know, just ensuring that they're you know, part of understanding their role in all of that as well.
Yeah.
Sorry, I interrupted you twice, I think. I apologise. Do you want to introduce yourself?
Yeah, sure. No, thank you. I'm Sarah Howard. I'm Deputy Director of Place, working with NHS Dorset. And thank you. It's been a really interesting afternoon. I'm here observing, but I've got a couple of things I'd like to mention, if I may. One is just building on Paul's comment around the GP engagement. I am aware that there is actually a health-focused, place-based group that meets on a regular basis, chaired by Martin Longley, actually. So he would be the voice of that group that would come here. It is health-focused, but it's a way of really the GPs, the clinical directors, Dorset Healthcare staff and DCH clinical staff really meeting together to agree how they work more cohesively. So I think that's a really positive step. And I think, as I say, as Martin chairs that group and is part of this board, then the link is probably there. So that was just one point I just wanted to make. The other was just coming back to the conversations. not necessarily for now, but maybe perhaps at a future meeting. I'd be more than happy to come along with a couple of colleagues to talk about the Portland Together project.
Yeah,
there are a couple of people here in the room that are part of that conversation and, you know, within the steering group. But to date, we've had 33 conversations with a really wide range of individuals, really insightful conversations. And we're planning kind of next steps in terms of how we take that back and engage again with the community in terms of, you know, we've listened, these are the things we've heard. But as I say, more than happy to present in a bit more detail, perhaps at another board meeting.
Thank you, Sarah.
I just wanted to flag out, sorry, Margaret Guy, I'm Vice Chair of Health Watch Dorset, but I'm also Chair of the Swanage Medical Practice Patient Participation Group, otherwise known as a PPG. And we had a meeting last night, and so there was, I actually flagged up this plan for them. I've sent it to them to look at this morning. So I think that that's another forum. There's virtually every practice in Dorset has a PPG. That's groups of patients meeting together. And so there's an opportunity there to actually hear what people are saying on the ground. We had actually a presentation from the lead district nurse for Purbeck last night. Really interesting and informative, and it sort of sparked off lots of other conversations. And last time we had Wellbeing Swanage, who is another community-based coming together group that's working in Swanage, and Kim Gallagher gave us a presentation. And as a PPG chair in Swanage, I meet with other PPG chairs in Purbeck, and there's actually you were at our meeting, which was a wider group with the PPG chair and other people talking about action, health and care in Purbeck. So there are these bottom-up groups that are happening, and we need to be making sure that we're linking in with those as well. Because nobody at the meeting last night, except for me, knew about this plan, should I say.
That's really interesting. And in the South, there are all these pieces of work going on. It's just ensuring that this is all linking in.
And they don't understand what NHS Dorset is, what's a PCN. It's so easy to say acronyms. Had to explain what a primary care network is. So the lack of understanding and knowledge at sort of really patient level, and trying to explain that, and then helping people understand how they can work together and influence things, So it's another forum. And Jill Foote is our link from NHS Dorset, who normally comes to our meetings. So we do have that link, but it's trying to keep, there's that opportunity to actually talk to a lot of people across Dorset by linking in with PPGs.
Thank you for that. Are there any? You've got a hand up on screen. I can't see that far.
Hello.
Hi. Good afternoon, Rich Bell, Dorset Police. Fascinating conversation. Thoroughly enjoyed it. One of the questions I've got is, and it links into Teresa's point about social mobility, but it's also a little bit broader than that. So we probably lose some of our young people out of the county as a result of opportunities which are available in the county, and we probably attract a older generation back into the county. So how do we map that against the ambition of the plan and the seasonal demand which is generated to actually identify our true success? Because the young people which we invest in, some of those will leave the areas, and the older people which we attract in retirement or for other opportunities, we haven't been able to influence their younger years and their health and their well-being.
Teresa.
Thank you. So thanks, Rich. And it's a real challenge for us, isn't it? How do we keep our young people here with interesting job roles and creation? So we're working very closely with DFE around this 16 plus, 18 plus offer in the county, and hopefully, next year certainly more news on that in terms of some richer offer, we're hoping, so that young people don't leave our county. However, we also know that we need them to have the good work opportunities here, and I think as has already been said, having business much more closely at this table and other tables, and really making sure that there's good opportunities for people to come into Dorset, and that economic regeneration piece is an area for us to look at with that. Our young people generally tell us they don't want to leave. It's not kind of something that they've got these itchy feet for particularly. It's a place they love to be, but the opportunities are just not there. So we do need to work with the business and innovation world to get that happening more.
Can I just say something, Jane?
Yes, sorry.
So I think there's we've sort of come to realise that the system-wide people fund that we've all put together is actually not just about supporting public service to employ the right people and be fully staffed. It's actually really critical to the success of our activities. So we need to think about it in a much broader sense. And so that sort of work that's being done at the ICP around what does to live here is important if we're then going to engage in a conversation with business. The things I think that are very specific to health are the fact that the conversations with some of our local DFE further education colleges that are about the links that they can form with our universities, so they're providing degree level education where people have to travel, and that's really important. The NHS broadening the spectrum of apprenticeships through the long-term workforce plan is really important, that people will be able to access good careers, not having to have a huge amount of qualifications, but being able to take through an apprenticeship. And we're even going to start an apprenticeship for doctors, recognising that nobody wants to leave university and then do 7 to 12 years of training and end up with £100,000 bill behind them that all came towards their credit rating. So we're going to introduce in the next couple of years degree level apprenticeships for a whole range of professional and non-professional careers.
That's exciting.
We've developed a degree with Bournemouth University that is linked to the ICB, and that's about helping people work through what roles they can have in not just in the NHS, but thinking about social policy and that kind of stuff. So we're really proud of that. We're sort of in year 2 of that. And then the other thing we've done is, which has been a lot of work with Neil as well, is forming some really strong links with Bournemouth University and Bournemouth Arts University, where we've got students who now are either working in the ICB or who will be coming into the ICB over the next few months to do a work placement that will be for 3 years, which will then be their research project for their degree. So it's getting them in really early, using the skills and the support they've got from the university to support some of the transformation programmes that we're going to be running, with the intention then of showing them what it can be like if you have a job in Dorset, and even for some of the students that are coming from outside of Dorset, hoping that that's then creates a catalyst for them to stay because they're in a career that they're really enjoying, and it's also contributed to their degree education. So there's a whole raft of things going on, but I think we do need to work more closely as a system around the people agenda, so we're maximising all of our opportunities to create good careers for people, which, because we know that most young people now are going to have 5 or 6 different career opportunities before they end their working life, because they're going to be working for 60 plus years. And God knows, I mean, it might even be longer than that. We think the pension age might move away from 67. So how do we create careers that makes it easy for them to move to another, easy for them to move from one organisation to another, easy for them to move from one sector to another? And how do we also understand what good work looks like for them, so that we are providing jobs and careers that they want to do? So, you know, one of the things we're looking at is how do we support people to work affordably? Because the reality is, all of the pilot studies that have been done say that if you pay somebody for 5 days work, but they only work 4 days, you actually get 5 days out of productivity out of them, because they know they're looking forward to a 3. And so we've got to be a bit brave around some of that stuff and really try it, because if that means that we are creating jobs that people want to do and it keeps them in Dorset, then we've got to be a bit courageous about giving some of that stuff a go.
Interesting.
There's been loads of research done on what good work is for young people. And it's not what we in an older generation think is good work. They don't want to commit to public service and work really long hours because it's a vocation. They don't. They want more information that supports them to make decisions at work, because they're less likely to take risks on judgment. So they want more flexible hours. And there's a whole range of things that we need to start to think about now that are not traditionally how we see good work.
They have very strong ideas about that.
They do, they do.
Very, yeah.
Even when we look at consultant careers in the NHS, we have just as many women now who want to, just as many men as women who want to start a consultant career out 4 days a week, because they can play golf or do something family orientated on the 5th day, and if you can survive on 4 days of the salary, then yeah. Where traditionally they'd have gone into a 5-day job and be working 100 hours a week, much more hours than they're paid for. Things have changed. The way that people see life has changed, and we've got to be able to move along with it.
Things are absolutely in the working. Honestly, interesting, really interesting initiatives there that you highlighted, and you know, what's the anchor institutions,
yeah,
of which
yeah,
NHS is, and obviously the local authority is as well. You know, and those things that we can be doing, you clearly are, and they sound, you know, those initiatives that you're working on with Bournemouth Uni. Yeah, that's exciting, and that, as you say, you'll be having people who are coming in. They're then having 3-year placements, and they're liking it here, and they want to stay, and they have buy-in because they've done this piece of work which is important to them. So, you know, you're future-proofing in that sense.
And also understanding where your workforce is coming from, because if you know you've got 10 areas of high deprivation in the local authority boundary, we're really clear that the people we're employing is geared towards those areas to support them with social mobility. And if it's not, understanding why and what do we need to do to change that. Because Weymouth is a great example. If you look at Weymouth, on the surface it appears as if you've got full employment, but when you scratch underneath, the majority of it is 0 hours contracts in hospitality. So why are we not getting those people in to public service? It can't all be about qualifications. There must be something we're doing that makes the jobs or the conditions or the hours not attractive to them.
I think we could this is
talk about it forever.
We could absolutely, but we can't, not today anyway. Thank you. Was there anything else you wanted to I mean, you know, you've got a ball rolling there with a really interesting level of conversation and debate.
Yeah, so like I said, so thank you, Annie. It's really exciting about the opportunities we're looking for young people and trying to develop that. It's just that the older generation, because we do attract then people from of retirement age. So how do we factor that into some of the outcomes you're seeking to achieve, so that we get a true understanding of what we have delivered and the benefits of that?
And those people who are coming in, who are that age, you know, they come in with vast experience in whole ranges we can't even imagine of things. And I know they very much get involved with voluntary and community and charity sector. And there's been a lot of discussion in the council about changing the narrative around older, maturer people, because they have so, you know, huge coming with huge things to offer, you know, and not just the voluntary community sector, but also to young people as well. You know, this young versus old, and it's not really necessarily a healthy kind of different. Teresa's giving me the hand there.
So sorry, it just so it's for instance the 100,000 years.
Yes.
So, you know, and life expectancy. So if we are attracting a retirement cohort which we've not invested in through their health and well-being throughout their life, how do we look at their healthy lifestyles or unhealthy lifestyles and how that impacts upon some of the outcomes we're seeking to achieve in Dorset, as opposed to the, you know, the values that they bring to the communities? That's undoubted, but we haven't been able to influence or support them throughout their development.
I think, I mean, thank you very much, Richard. It's really good question and a good challenge. It comes back to a couple of things. It's about data and understanding, and the data that's out there. We know the sort of people who want to come to Dorset, their health. We can track these things. It has to be factored into the maths so that we don't get a buy and we get healthy people coming in and we haven't actually done the work, or vice versa. I think that's really important. And again, it's about numbers. It's about good public health. It's about tracking these things and understanding. But then, as you also say, making sure we get all the benefits of people coming in, all those skills, all that support for businesses and voluntary sector as well. But I don't think that the numbers will lie, but it does reiterate why we have to track clear numbers rather than just saying, oh, it's not our fault. Lots of people come to Dorset to retire and fall over and break their hip. It's not our fault. We need hard data that tracks our performance. And this, we can do it, but we have to do it properly, I think. But Sam, I was probably putting all over you saying it in a better way.
It's a really
social engineering going on.
it's a really good point. But I've been thinking about this for a long time, and sometimes we make the mistake of looking through the wrong end of the telescope at the importance of deprivation when we're looking at health. Okay. So in Boscombe, where I live, everyone always says it's one of the most deprived neighbourhoods. It's in the top 2% most deprived communities in the southwest if you're looking at lower super output areas. But I live there and I'm very well paid, so that's not the whole story. The other issue is that you get an effect caused by the housing market where a lot of poor health is attracted into that area because it's the cheapest place to get a unit of accommodation. Yeah. So there are things that happen which are nothing to do with the intrinsic environment where people may or may not have grown up. Yeah. When we look at the healthy life expectancy data, I understand what you're saying about people importing their previous health experience into the county, but by far the biggest issue is the difference in the number of years that people live in good health if they've been brought up in the most deprived communities compared with the more affluent communities. And you talk to GPs that practice in those areas. These are not people who are coming into Dorset. The people they're seeing who are developing diabetes in their 40s are people who've lived in that community for a long time. Mm-hmm. And that's completely different. If you talk to a GP who's practicing in Verwood or East Dorset, they'll say it's rare to see anyone with those kind of long-term conditions before late 60s or 70s. And that's a pattern you see, unfortunately, all over England. And it's that social gradient is where we're going to make the biggest difference. So yeah. I would say we need to focus our efforts even more on moving some of those resources, not just money, but time and capacity for really understanding what's going to make a difference and keep people engaged in their health and developing more ownership and interest around that. And it's going to be a long process. It's not going to be a quick win, but that's what we need to do, and that's where we make the biggest difference. And just a footnote to that, if anyone's looking at the Health Foundation podcast at the moment, the healthy life expectancy data is nosediving in this country. So it's really unusual that we've had sustained growth year on year. And then since the pandemic, it's started to go in the opposite direction. So I think it's a really brave plan. I've been in and around the system for a long time, and I haven't seen many publicly published plans that have actually committed us as a system to say we're going to be brave and bold and put some numbers around this and commit to it over the medium to long term. So I sort of applaud everyone who's been involved, really, but the hard work sort of starts now.
Thank you, Sam. And everyone who's contributed, thank you. Was there anything else? Did you want to? You're on green.
Yeah, very briefly, only to thank again. This is such a great conversation and really revitalises hopefully everyone around the table. And I know it says it's recommended that members note and support, as we always say in quite dry words, but I'm going to just add to that, please, challenge and then work together to deliver, because we are going to have to hold our nerve on this, because other numbers will come up and pressures will come from region and government and different groups. So we're going to have to really hold our nerve. And the final thing we haven't talked about much today, but we're going to have to take risks and innovate. We can't wait for make perfect the enemy of good. We're going to have to go out there on a limb and do things where we've got most of the data. So we all hold our nerve, we take risks and innovate, but we believe in this, then I think we're going to do it.
Thank you. Red now. Thank you.
No pressure, Neil.
Thank you. Thank you very much. Right, we are now going to move on to agenda item 9, the work programme.
Chairman, I'll just excuse myself. I've got.
Yes, absolutely. And anybody else who's wants to.
I want to.
What do I need to do, George?
Right, yeah. So we need to go through that at the meeting.
It's on at number 9.
And
so
just should
we do those and exempt business, yeah. and then we close down? Yeah. Okay.
If you just and that's That's so public.
So we're going to have a short development session which will take place after the meeting to develop the plan. Thank you. Are there any urgent items? No, I don't have any. And no exempt business?
No.
No, thank you. Thank you very much, George, for keeping me on track. And now we can close the meeting. Thank you.